My name is Dr. Khan. Let us start with this topic of optics and refraction. Optics and refraction, one of my favorite topics in ophthalmology. Optics and refraction. Now guys, in this optics and refraction, what we need to discuss is about the refractive errors that is commonly faced by the public, okay? Or that is commonly faced by you or me or your parents at your home. We are discussing about those refractive errors. So guys, if a person is there who is coming to you and telling that, doctor, I am not able to see the far things properly. I am able to only see the things which are at a shorter distance properly. That person is short-sighted. Short-sighted means what? Only short-sight things he is able to see properly. But far things he is not able to see. He is called as a short-sighted or myopic. He is called as myopic. Okay. Then there is a person who will be coming to your clinic and telling the doctor, I am not able to read the newspaper properly. I am not able to read the newspaper properly. You will be asking, how's your far vision? He is telling, far things I am able to look very clearly, but the near things I am not able to read. So, any person who is not able to read the near things properly, but far things he can read properly, he is called as far-sighted. He is called as far-sighted. Far-sighted means what? Far vision is normal, the near vision is at problem. So basically, if you don't remember short-sighted and far-sighted, remember what? Myopic and hypermetropic. Myopics means they are not able to see the far things properly. Hypermetropic means they are not able to see the near things properly. Okay? So remember, we are discussing about what? We are discussing about the optics and refraction. In optics and refraction, the first thing that we need to know is emmetropia. What is meant by the term emmetropia? Just look over here, guys. Imagine this is the eye. This is the eyeball. The second layer of the eye is choroid and the innermost layer is the retina. This is the innermost layer, which is the retina. So, whenever emmetropic, when do you say a person emmetropic? Yani the light rays from infinity focuses on the retina. Light rays traveling from infinity focuses on the center point of the retina. He is called as emmetropia. Normally, the ones without glasses who are listening to this lecture without glasses, their light rays are focusing on the retina. Yani कि they are having no power problem. Yani कि they are emmetropic. Then there is a condition called as ametropia. Ametropia. What is ametropia? Ametropia is further divided into myopia, hypermetropia, and it is also divided into one more thing which is called as astigmatism. Myopia, hypermetropia and astigmatism. Myopia meaning what, guys? Once again with the diagram we will remember that so that we can easily remember. Okay, this is the retina. Myopia meaning what? Light rays traveling from infinity and focusing before the retina. This is the retina, right? Focusing before the retina. That is called as myopia. Light rays traveling from infinity and focusing in front of the retina is called as myopia. Then there is hypermetropia. Light rays traveling from infinity and focusing behind the retina. Focusing behind the retina. That is called as hypermetropia. Hypermetropia. Myopia, the light rays are focusing before the retina, hence they are not able to see the far things. Hypermetropia, the light rays are focusing behind the retina, hence they are not able to do the near activity properly. So, one is myopia, other is hypermetropia. And the last problem is what, guys? Astigmatism. Astigmatism. Now guys, what is meant by astigmatism? Just look over here. right? This is the retina. Astigmatism meaning what? Light rays focusing on the retina, but one more light ray is focusing either in front of the retina, that is called as myopic astigmatism, or there is one more light ray is focusing behind the retina, that is called as what? Hypermetropic astigmatism. यानी कि astigmatism यानी कि two different foci of light rays are focusing. One is focusing on the retina, one is focusing at the other part, two different foci, that is called as astigmatism. So basically remember guys, we are talking about what? Emmetropia. Emmetropia yani ki light rays traveling from infinity and focusing on the retina, that is emmetropia. Ametropia is divided into myopia, hypermetropia and astigmatism. What is myopia? Light rays traveling from infinity focusing in front of the retina, that is myopia. Light rays traveling from infinity focusing behind the retina, that is hypermetropia. Astigmatism yani ki two different foci of light rays being formed, that is called as astigmatism. So first talking about what? Talking about myopia. Talking about myopia. Come on guys. The complaint of the patient who is suffering with myopia, he complains of what? He complains of what guys? He complains that he is not able to look at the far things properly. That's a complaint. But why is the patient having myopia? What is the cause? What is the cause to develop myopia? There are three causes of myopia guys. One cause is based on the axial length, other cause is based on the refractive index, the third cause is based on the corneal curvature. There are three causes of myopia. One is the axial, other is the index myopia, last is the curvatural myopia. Okay, axial length. Remember guys, what is the normal axial length? The normal axial length of the eyeball is how much? The normal axial length is 24 mm. At birth, the axial length is how much? 16.5 mm. Okay, but remember guys, we are discussing about the causes of myopia. There are three causes of myopia: axial, curvatural and index myopia. Axial myopia means what? If the axial length of the eyeball is much large, then it leads to axial myopia. If the length of the eyeball is large, remember guys, if the length of the eyeball is small, or if the length of the eyeball is in the medium size, on an average size, the light rays will focus on the retina. But if the eyeball is growing abnormally large, then what will happen? The light rays can't go back, no. Eyeball is increasing in diameter, the light rays can't go back to the retina. So, light rays will focus much before the retina, leading to what? Leading to myopia, right? So have you written guys? The axial length of the normal axial length is how much guys? It is 24 mm, and at birth it is how much? 16.5 mm, 16.5 mm, right? So that's regarding what? Axial myopia. For every 1 mm of extra axial length, how many diopters you have to add? You have to give -3 diopters glass. Every 1 mm extra of axial length. Normal axial length is 24 mm. Every 1 mm extra you have to give -3 diopters. -3 diopters, right? So if the axial length is 25 mm, -3 diopters. If the axial length is 26, -6 diopters. So guys, imagine there is a person who came to my clinic and I prescribed him -21 diopters glasses. What does it mean? I have given him -21 diopters of myopia. How much will be his axial length? Come on guys. Every 1 mm, how many diopters? -3 diopters. So basically 21 divided by 3 is equals to 7. So 7 mm is extra. Every 1 mm is 3 diopters. 21 divided by 3, 7 mm is extra. The normal axial length of the patient is 24. But 24, my question is, I gave 21 diopters of glasses to the patient. What is his axial length? His axial length is, normal axial length is 24. Plus how much is it? 7. So it is 31 mm. Altogether, remember, every 1 mm increase in the axial length, how many diopters you have to give? -3 diopters. -3 diopters. This is regarding what guys? Axial myopia. That's regarding what? Axial myopia. What is the complaint of the patient who is suffering with axial myopia? If it is a child, the parents will be coming with the child and saying that, doctor, the teacher of the child is telling that the child is sitting at the back bench and while looking on the board, he is squeezing his eyes. Guys, when you are not able to see the far things properly, you try to squeeze your eyes so that the light rays will focus on the retina. So myopics usually try to squeeze their eyes in order to focus the light rays on the retina. The parents will be complaining what? In the classroom, the child is not able to see the blackboard properly, and when he is at home, while watching the television, he is watching the television with half eyes shut. Okay? Symptoms of myopia. The child will be watching television half eyes shut. Watching television half eyes shut. That is the complaint of the patient who is suffering with myopia. Okay. So anyways guys, we are talking about axial myopia. Larger eyeball leads to axial myopia. Every 1 mm increase minus 3 diopters. That is axial myopia. Next is what guys? Curvatural myopia. Curvatural myopia. What is meant by curvatural myopia? Curvatural myopia. Remember guys, our cornea at some places it is spherical and at some places it is curved, right? But if our cornea becomes very much curved like this, if the curvature of the cornea increases, the patient will have light rays focusing much before the retina. That myopia developing due to the problem in the corneal curvature is called as curvatural myopia. Every 1 mm of extra curvature, you have to give 6 diopters. You have to give how many diopters guys? 6 diopters. Okay? There is a patient who is suffering with keratoconus. You know what is keratoconus? There is a condition where the patient is suffering with what? Patient is suffering with keratoconus. What is keratoconus? Conical shaped cornea. Conical shaped cornea. In conical shaped cornea, how will be the, what will happen to the patient? Yani ki patient is having a conical shaped cornea. What will happen now? The light rays will focus much before the retina and the patient will become highly myopic. So remember guys, curvatural myopia means 1 mm of extra curvature of the cornea, it leads to minus 6 diopters. Yani ki if the curvature is increased, the light rays will focus much before the retina. That is called as what guys? Curvatural myopia. Curvatural myopia. Okay. Now guys, remember, the light rays as they are passing, they bend. Okay. The light rays bend, the light bends when the rays pass from one medium to the another medium. The light will bend from, we'll start from here. The light will bend when the rays pass from one medium to other medium. There is basically four points at which the light will bend. First, before entering the eye, the light bends in the air. Second, at the cornea. Third, at the anterior surface of the lens. Fourth point is the posterior surface of the lens. Okay? First is the air, second is the cornea, next is aqueous humor. Cut this point. Right. Once again. Light rays before focusing on the retina, you will see altogether 4 bendings. The light rays will bend and then it will focus on the retina. There are 4 bendings. First, it will bend in the air. Second, in the cornea. Third, in the aqueous humor. And fourth, at the posterior surface of the lens. Posterior surface of the lens. There are 4 mediums at which the light rays will bend and will reach the retina. That is again guys, come on. We are discussing the 3 causes. First cause is what guys? Axial myopia. Second is what? Curvatural. And third cause of myopia is index myopia. Index myopia is not that common, but index myopia, when does it occur? When the patient is suffering with a disease called as nuclear cataract. Whenever a patient is suffering with nuclear cataract means what? cataract occurring on the nucleus is called as nuclear cataract. When a patient is suffering with nuclear cataract, it increases the refractive index of the lens of the nucleus by, normal refractive index of the nucleus is 1.4, so it will increase the refractive index from 1.40 to 1.42. As the refractive index is increased, what will happen to the light rays? The light rays will focus much before the retina. We have discussed this in cataract, guys. We have discussed in this nuclear cataract. In nuclear cataract, you will see Ametropia. In nuclear cataract, you will see myopia. I told you. Okay? So, any myopia developing due to change in the refractive index of the lens is called as what myopia? Index myopia. In case of nuclear cataract, it increases the refractive index from 1.4 to 1.42 and hence converges the light rays much before the retina, causing myopia. So, I told you guys, usually myopes are called as short-sighted. Why they are called as short-sighted? Why? Because they see the near things properly. Far things are not seen properly by myopics. So guys, remember, any person who is suffering with myopia or hypermetropia or astigmatism, you have to give some treatment. What is the treatment for myopia? For myopia, you give some lenses. Basically, imagine a patient is having myopia. Okay, this is the eyeball, this is the retina. The light rays are focusing over here. Okay. If a patient has myopia, we give them some glasses. What glasses, guys? Concave glasses. Myopics always go into cave. Hence, they are called as concave. So, when you give concave glasses, what will happen to the light rays? Light rays will focus on the retina. So, treatment of myopia is giving concave glasses. Whereas, treatment of hypermetropia is what, guys? You have to prescribe the patient convex glasses. Convex glasses. Convex glasses, if you give, it will focus the light rays on the retina. Okay. So, anyways, guys, we need to prescribe concave glasses for myopia. That is the first line of treatment for all refractive errors. The second line of treatment is giving contact lenses, but the first line is the glasses only. Myopics glasses are usually having negative powers, minus power. Okay? Why? Because myopics, when we give concave glasses, it will minify the things on the retina. It is used for minification. Hence, minus power. Okay? Every one diopter, every minus one diopter is equals to 2% of minification. 2% of minification. For index myopia, we can go for, remember guys, index myopia meaning what? The patient is having problem in the lens refractive index. So, you can remove the nuclear cataract and you can place a other intraocular lens. Okay. So, remember guys, for index myopia, surgical correction can be done, that is IOL placement. Right. That is regarding what? Myopia. But in myopia, there are some other problems also the patient. Yani a patient who suffers from myopia will also have some other problems. What problems he'll have, guys? He'll have a thin cornea, he'll have a deep anterior chamber, right? Other problems seen in myopic patients are, as remember, the axial length of myopic patient is usually large. As the eyeball is growing and all, they'll have a thin cornea, they'll have a deep anterior chamber, they'll have some lattice degeneration. Very important, guys. Lattice degeneration occurring in the retina. You will see some spots developing, which is called as Foster-Fuchs spots. Foster-Fuchs spots. And as the eyeball diameter is high, so as the eyeball diameter is large, sometimes the retina might detach. That is called as retinal detachment. That's called as what, guys? Retinal detachment. Apart from that, as the eyeball is large, sometimes one part of the sclera or one part of the choroid might get weak. That can lead, sometimes a part of sclera gets weak and that leads to protrusion, which is called as staphyloma. Okay. So, myopia, any person who is suffering with myopia due to large eyeball, they are having many problems, guys. They will be having thin cornea, they will be having deep anterior chamber, they will be having lattice degeneration, they will be having Foster-Fuchs nodules, developing, right? And apart from that, retinal detachment they are at higher risk of developing what? Retinal detachment, and sometimes staphyloma also. These are the things that are suffered from what? That are suffered with, that are seen with myopic patients. Myopic patients. Coming to the second refractive error, which is called as hypermetropia. Come on guys, we'll define hypermetropia first. What is hypermetropia? Hypermetropia meaning what, guys? Rays of light traveling from infinity and focusing behind the retina is called as hypermetropia. Now guys, what is the cause of hypermetropia? The cause of hypermetropia is same like myopia. Same like myopia means three causes. What three causes, guys? Axial hypermetropia, curvatural hypermetropia, and index hypermetropia. Axial, curvatural, and index hypermetropia. What is that? What is meant by axial hypermetropia? Axial hypermetropia is always opposite of axial myopia. If remember guys, normally axial length of the eyeball should be 24. If it increases much, myopia. If it decreases, if it is not at all increasing, and again it has not attained 24, it is just 18 or 19 mm, then the small eyeball, what will happen if there is a small eyeball? Light rays will focus behind the retina. So axial hypermetropia means what? Hypermetropia developing due to shortening of the eyeball, right? Due to shortening of the eyeball, right? So axial hypermetropia, it is a hypermetropia that occurs due to shortening. Yani it's not that the patient will develop a 24 mm, then the eyeball will shorten. No. The patient is developing and the eyeball is still developing, and now at one stage it has stopped at 20 mm. Yani if it has stopped developing, then it leads to hypermetropia. Yani hypermetropia that occurs due to axial length of the eyeball. Axial length or shortening of the eyeball. Every 1 mm shortening of the eyeball gives you how many diopters, guys? Gives you plus 3 diopters. Every 1 mm lengthening of the eyeball, minus 3. Every 1 mm shortening of the eyeball, plus 3 diopters. So any person who is developing hypermetropia due to shortening of the eyeball is called as axial hypermetropia. Second is curvatural hypermetropia. Once again guys, in curvatural hypermetropia, what was curvatural myopia? I told you cornea is spherical and curved at some places. Too much of curving of the cornea can lead to curvatural myopia, whereas too much of flattening of the cornea can lead to curvatural hypermetropia. Curvatural hypermetropia meaning what, guys? Flattening of the cornea. Flattening of cornea can lead to curvatural hypermetropia. Flattening of the cornea can lead to curvatural hypermetropia, right? Now guys, every 1 mm flattening, just right there, every 1 mm flattening of cornea gives you 6 diopters. Gives you how many diopters? 6 diopters. There are a few conditions where you see a flat cornea, such as sclerocornea or cornea plana. Sclerocornea or cornea plana, where there is too much of flattening of the cornea that leads to what? Curvatural hypermetropia. The third cause of curvatural hypermetropia is what? Index. So the third cause of hypermetropia, remember hypermetropia, the first cause was axial, second is curvatural, third is index. Index meaning what, guys? Some problem with the refractive index of the lens. What is the refractive index of the lens at the nucleus? 1.4. If it is increased, it leads to myopia. So in nuclear cataract, you will see the patient developing what? Myopia. Whereas if the patient develops cortical cataract, if the patient develops cortical cataract, it decreases the refractive index that leads to focusing of the light rays much behind the retina, That is called as index hypermetropia. When the refractive index becomes low in cases of cortical cataract, the refractive index becomes low, and what will happen? The light rays will focus much behind the retina. I was telling you that index hypermetropia means due to cortical cataract, if there is a cataract developing at the cortex of the lens, it will basically decrease the refractive index that leads to focusing of the light rays much behind the retina. That is called as index hypermetropia. Right? So when the refractive powers becomes low in cases of cortical cataract, you will see water silk appearance of the fundus, which is seen in hypermetropics. This is regarding what, guys? This is regarding the 3 causes of hypermetropia. The first cause of hypermetropia was what? Axial, second is curvatural, third is index hypermetropia. Now guys, when the child is born, at birth, what do you see? At birth, what do you see? First, have we written about? Yeah, we have written about it. Okay. At birth, what do you see, guys? At birth, how is the axial length? At birth, I told you axial length is 16.5 mm. It is having a short axial length. At birth, as the baby is having a short axial length, just right there, guys. At birth, the baby, the child will be always hypermetropic. Why they will be hypermetropic, guys, at birth? Why? What's the reason? What's the reason? Why? Because they are having a short axial length. They develop a normal vision at least by 4 or 5 years. They develop a normal 6/6 vision at least by 4 to 5 years of age. At this age, they will develop a normal vision. Okay? Sometimes, some children might develop myopia at 7 years of age. At 7 years of age. And basically, the child will be brought to the hospital saying that the child is not able to see the things properly, watch the blackboard properly, or he's watching the TV with half eyes shut. That is called as what, guys? 7 years. Myopia developing at 7 years or school going age is called as what? It is called as school myopia. It is called as what, guys? School myopia. Some children develop myopia during 14 years. During 13 to 14 years. As during the adolescent phase, their eyeball suddenly grows much. So what will happen? They develop myopia at this age. Developing myopia at 13 to 14 years of age is called as adult myopia. It's called as what, guys? Adult myopia. But whether it is school or adult myopia, it gets automatically corrected if at the age of 21. If at the age of 21, if the eyeball stops the growth at 24 mm, and again eyeball has now stopped the growth at 24 mm, it will get automatically corrected. No need of wearing the glasses and all. So remember, guys, we are talking about what? At birth, the baby's eyes are very small. The light rays are focusing much behind the retina. Then the child is called as hypermetropic. Hypermetropic by how many diopters, guys? 2.5 to 3 diopters. 2.5 to 3 diopters. He develops a normal vision by 4 to 5 years of age. By 7 years of age, he will become if at all patient develops myopia, that is called as school myopia. 14 years of age, adult myopia. Both will get automatically corrected if the eyeball at 21 years stops growing, or if it stops growth at 24 mm, then the person will be emmetropic. So that's regarding what, guys? That's regarding the hypermetropia. If a person is suffering with hypermetropia, the complaint of the person is what? What's the complaint of the patient, guys? First, we have to discuss the complaint. Then we need to discuss the treatment, guys. The complaint of the patient of hypermetropia is what? Sir, I am not able to see the near things properly. If he is not able to see the near things properly, what will this guy do, you know? Without, first he is not able to read the near things properly. He will take this chart and put this chart near his eye or put this newspaper near his eye and try to accommodate. Due to this excessive accommodation, this patient will also complain of what? Headache. And any headache that is occurring due to problem in the refractive error, is called as astigmatism. Headache developing due to problem of the refractive error is called as astigmatism. So myopic patient, hypermetropic patient complains of what? They complain of not able to read the near things properly. Second, they complain of headache due to excessive accommodation. And due to this excessive reading, they try to, without glasses, they try to read the things by keeping here and here. What will happen, guys? They'll have headache, and sometimes as they are excessively trying to accommodate, their eyes will converge, and this hypermetropics might develop convergent squint. They might develop what, guys? Convergent squint. Whereas myopics, while looking for the far things, they might develop divergent squint. Okay. So hypermetropia and convergence are always linked together. So we are discussing about what? First, we are discussing about the clinical features. Astigmatism is the main complaint of the patient who is suffering with hypermetropia. Due to constant accommodation, the hypermetropic patients will develop headache. Right. So due to constant accommodation, they will develop headache. So guys, remember, when a person is suffering with when a person comes to your clinic for any of the problems saying that I am not able to see the far things or the near things, what do you need to do? You need to go for an eye checkup. You need to first check the eye and all. How will you check the eye? If it is a myopia, you take him in front of a Snellen's chart. But before making the patient sit in front of the chart, we first give some relief to the ciliary muscles. We put tropicamide solution so that his ciliary muscles are relaxed and all. Okay, so that we can exactly calculate the power of the eye and all. Okay, we can exactly calculate the the power of the lens. So before making the patient sit in front of the Snellen's chart for myopia, okay, start from here. For investigations, the test that could be done for myopia and hypermetropia, you guys know. For myopia, we take the patient for Snellen's chart. We make them sit in front of Snellen's chart and all. But before taking the patient towards the Snellen's chart, first we pour a drop called as tropicamide, which will relieve the ciliary muscles, so that you can exactly check what number glasses needs to be given to the patient and all. Okay, whether it's for myopia or hypermetropia, first we pour the tropicamide solution. Okay, next, remember guys, myopics, you have to make them sit in front of the Snellen's chart. After that also, you can, if at all you are suspecting some more things, you can go for slit lamp examination or ophthalmoscopy and all. But Snellen's chart, by Snellen's chart, you can say that this diopter glasses needs to be given to this patient and all. But guys, for near vision testing, what is the chart that we use? Come on guys, that chart is held at 35 to 40 centimeters. What is that chart called as? Jaeger's chart. That chart is called as Jaeger's chart. So you take the patient towards the Jaeger's chart and you tell him to read from bottom till top. Now, anyways, what will you do now? As you came to a conclusion that this patient is having myopia or hypermetropia, you came to a conclusion that this patient is myopic by -6 diopters, or this patient is hypermetropic by +6 diopters. What is the glasses that you need to give to this patient? For -6 diopters, for myopics, you give what glasses, guys? Myopics go into the cave, you give concave glasses. Whereas for hypermetropics, you give what glasses? Convex glasses. And while prescribing the glasses, a small hint over here, whether when a patient is being diagnosed with myopia, always, if at all, while testing, his sight is coming as -6 diopters, never give him -6 diopters, give him -5 diopters, always undercorrect the myopics, never fully correct the myopics. Whereas for hypermetropics, they have to be fully corrected. If it is +6, give him +6. Okay? For myopics, always you have to undercorrect the myopics. For hypermetropics, you have to always fully correct the hypermetropics. But if you don't fully correct the hypermetropic, sometimes if you are a new ophthalmologist and you have done a mistake, a patient is coming with the complaint, he is not able to read the near things. You have done the testing, his number came as +6, but you wrote +5 diopters. You wrote +5 diopters. What will happen? Never undercorrect the hypermetropic. If you undercorrect the hypermetropic, what will happen? The patient complains of the patient complains of severe headache. Why? Because he is undercorrected. Second, what will happen? This patient will develop presbyopia at a very early age. This patient will develop presbyopia at a very early age. We'll discuss what is presbyopia while discussing the last refractive error. Okay. So anyways, guys, remember, always hypermetropics needs to be fully corrected. Myopics needs to be undercorrected. If you fully correct the myopic, he'll have headache. Okay. So due to constant accommodation, we are discussing about the symptoms of hypermetropia as well as myopia. Remember, in hypermetropia, asthenopia is the main problem. Why? Because as they try to accommodate, and due to constant accommodation, hypermetropics develop headache. I told you the patient will develop a squint. The squint which is seen in hypermetropics develop. Hypermetropic patient develop what squint, guys? They develop convergent squint. Convergent squint. Whereas myopic patient develops divergent squint. Myopic patient develops divergent squint. Myopic patient develops divergent squint, right? And the rule is what? Always undercorrect the myopics. Always undercorrect the myopics. And other rule is what? Always fully correct the hypermetropics. Always fully correct the hypermetropics. Always fully correct the hypermetropics. But if at all hypermetropics are, if at all the hypermetropics are undercorrected, what will happen? They will have more headache. They will have more headache. If a myopic is complaining of headache, there are two reasons. Either he is wearing the glasses for the first time, or either he is fully corrected. So remember, for a myope, there are two reasons for headache. Either wearing the glass for the first time, or they are fully corrected. These are the two reasons. These are the two reasons for myopic to develop headache. Okay. So remember, guys, for myopia, we choose a lowest power with best vision, just providing the glasses that diverges the light rays and focuses on the central part of the retina. So we give what glasses for myopics? For myopics, we give concave glasses. We give what glasses? Concave glasses. Whereas for hypermetropics, what we give? We give convex glasses. We give convex glasses for hypermetropics. So when you compare myopics with hypermetropics, which one is better, guys? Treatment. So in the treatment, I told you guys, for treatment of hypermetropia, what is the glasses that we give? For treatment of hypermetropia, we give convex glasses or magnifying. Those will be that will cause magnification. Hence, it is plus given for hypermetropia. Whereas for myopics, we give concave glasses. If I tell you to choose between myopia and hypermetropia and tell you which one is better, which refractive error is better, always myopia is better. Hypermetropia is not a good refractive error. Imagine there are two patients, A and B. Both are suffering with myopia and hypermetropia. One is suffering with myopia from the last 4 years. Other is suffering with hypermetropia from the last 4 years. They both come to your clinic. You give glasses to them. Okay? You give glasses to them. Okay? Both refuse to wear the glasses. After 1 month, both come to your clinic. You again go for the testing. What will happen to their vision? Their vision is 6 by 60, 6 by 60. Right? Patient A vision is 6 by 60, B is also 6 by 60. Now you are telling them, counseling them, if you don't wear glasses, you will become blind and all. So now they are listening to you. My myopic patient is also listening to you. Hypermetropic is also wearing the glasses. After 2 months, if they come to your for eye checkup, this myopic patient who was having 6 by 60, his vision will improve to 6 by 18, whereas hypermetropic's vision will be 6 by 60 only, whether it is he is wearing the glasses or not. Okay? But if he won't wear the glass, he will become blind. But remember, is the vision improving? No improvement. Myopic's vision will improve after wearing the glasses. Hypermetropic patients' vision will be just kept at the same position only. Okay. So remember, guys, why? Because hypermetropics, if they are not taking the things seriously, what will happen? If hypermetropics are not fully corrected, what will happen, guys? They will develop amblyopia. They will develop amblyopia very easily. So remember, guys, if there are two patients, one suffering with myopia, other suffering with hypermetropia. Okay, from 4 years they are suffering and you give them glasses. After 4 months, if you check the vision, myopic vision will improve. Hypermetropic vision will not improve. Neither it will become worse. It will just stay like that only. Why? Because hypermetropics develops amblyopia easily, right? So which one is better, guys? Myopes are always better. Myopes are always better. Why? Because they will be having improvement in the vision. Whereas hypermetropes, they will develop amblyopia easily. They will develop amblyopia very easily. So, which one is better? Myopia or hypermetropia? Always it is myopia, which is better. Okay. So, guys, when you compare myopia with hypermetropia, okay, who will be having problem with the far objects and all? Myopics. Okay. Who will be having headache most of the time? Hypermetropics. Okay. Myopics will have what kind of squint? Divergent squint. Hypermetropic, convergent squint. Okay. Apart from that, who are fully corrected? Hypermetropics. Who are undercorrected? Myopics. So when you compare hypermetropia and myopia, short-sighted is myopia, far-sighted is hypermetropia. Concave lenses are given for myopia, convex is given for hypermetropia. Remember, guys, if you are a myopic, you will wear the glasses close to your eye. Why? Because you have to focus on the far things. Far things are not seen, right? So you have to wear glasses close to the eye. Whereas hypermetropics always wear glasses on the tip of the nose. Reading glasses. Why? Because they just require for near things. So hypermetropics wear the glasses on the tip of the nose. One will cause minification. Myopics, the concave glasses will cause minification, whereas hypermetropics, convex glasses causes magnification. Accommodation. Accommodation is a problematic thing in hypermetropia, but with the convex glasses, it becomes good. Okay? Divergent squint is seen in myopia. In hypermetropia, convergent squint is seen. Myopics are undercorrected, hypermetropics are fully corrected. I told you who will have headache. Myopics will have headache only for two reasons, either wearing the glasses for the first time or either they are fully corrected. Whereas hypermetropics, normally they complain of headache all the time. Why? Because if they don't wear the glasses, due to constant accommodation or due to constant accommodative action of the ciliary body, the patient will have headache. That's regarding what, guys? That's regarding the myopia. So I told you guys, if you want to assess, if the refractive assessment has to be done, it can be done by either Snellen's chart, Jaeger's chart, or objective refractive assessment can be done by retinoscopy. How will you assess the patient's power and all? So I told you Snellen's chart, and Snellen's chart is done, Jaeger's chart is done. Snellen's is used for myopics. Guys, you remember for if it was Snellen's is used for literate patients. If the patient is an illiterate and he's suffering with myopia, what is the chart that we used? What is the chart that we use? Illiterate E chart or Landau's ring. For preschool children, Allen's chart or Lee's chart is used. For pre-verbal child, what is the thing that is being used? Optokinetic nystagmus. Okay. So anyways, guys, objective assessment of myopia can be done by retinoscopy, right? Retinoscopy. Retinoscopy is a gold standard. But before going for any refractive test, we first dilate the pupil by giving a cycloplegic drug. Either it could be atropine or tropicamide solution. Okay. Then you can go for subjective assessment. Objective assessment is by retinoscopy. Subjective is by Snellen's chart and others charting.